network thinks. Dr. Simwenda, I'm sure you can see the manner in which they come in. It's quite difficult to tell where the network is falling because we are getting almost an equal number of responses for true and for false. So I'll just allow 30 more seconds. Less than 100 out of the 183 connections. Please, let's vote. 10 seconds to go. Okay, so I'll end the poll and display the results. Sure, Dr. Simwenda, you can see the manner in which our network voted, and hope then will be clarified on the information related to this poll question. Dr. Simwenda.
Okay, thank you very much. Interesting results are there. And you could see people changing from one question answer to the other. So indicate whether this statement is true. In people living with HIV, the risk of progression from infection to active disease is 10% in the first 2 years of exposure. It's very interesting and it's also very important to look at evidence, especially as we manage our clients. It is very good at all times to utilize the evidence that we know in order to really improve the management of our clients. So it's not more. Okay, so the lifetime age-weighted risk of TB following infection in settings with low exogenous reinfection is estimated to be 12%, but the risk of progression from disease in people living with HIV is 10% in the first 2 years. If at all following up clients, with HIV clients, if at all you're following them up for 2 years, and out of 100, at least 10 of them will actually progress to infection 2 years after being exposed. So some evidence here, when we look at the incidence of TB in household contacts by infection status and intervention, a total number of 26,000 plus clients or patients were followed up for a period of over 10 years. And these were classified into the placebo that had a tuberculin skin test with that was positive, and then also clients that had a tuberculin test that was and were put on isoniazid, and equally there was another group that was tuberculin skin negative. So if at all, I hope the case are there. So if at all you this reduction if the clients that had a positive tuberculin skin test on TP. So in following and those ones that had not been with one or more symptom, you can see that those ones who were on TPT when followed up, and this was over a period of 300 days, you can see the ones that had no symptoms, the clients, the incidence of TB in the clients who were on TPT was actually lower as compared to the ones that were not on TPT. So again, in a study done in Ethiopia, where they followed up 2,524 people living with HIV as participants, we found out that a total number of 277 clients had TB. These were the new cases of TB. And the conclusion in this study actually was that IPT significantly reduced TB incidence in people living with HIV by 96.3%. Then again, there's another study, the Teprano study, which showed that 6 months of IPT equally reduced mortality by 79% at 78 months of follow-up. But when you look at clients at 5-year timeline, the reduction was 37%. And this was independent of ART. So there is a lot of evidence out there. And the reason why we are presenting this evidence is to equip us as healthcare providers to be very knowledgeable and also to improve our confidence in the management of our clients. There are clients there who are able to understand some of this, of course, in a simplified manner. So let us use this evidence also, especially when we're looking after clients who are difficult to initiate, who would say no if at all you presented this data in a simplified manner and say out of 10 clients that were followed up and were given TPT, 9 out of 10 did not have TB. So some of this evidence, or a lot of this evidence, actually we can simplify it and even utilize it at facility level as clinicians or as healthcare providers in order to improve the services that we are providing to the clients. So I'll hand over to Dr. Singini.
So for the next 4 questions, the next 4 questions says, true or false, indicate whether this statement is true or false. People living with HIV are not at risk of active TB disease when they are on ART and clinically stable, and even if CD4 count is greater than 700. I repeat that. People living with HIV are not at risk of active TB disease when they are on ART and are clinically stable, even if the CD4 count is greater than 700. So network, we have 260 connections now, and so far we're still under 10% of those that have voted. So I encourage everyone to participate. Dr. Simwenda, I'm sure you can see the pattern of the voting. We are seeing some people inclining towards true, others are inclining towards false. And as we give maybe 20 more seconds to the network to vote. Okay, so an interesting result showing here. Allow me to just display the result. Okay, so Dr. Simwenda, you can see that 89% of the respondents thought false was the correct answer, and just about 19 out of the total respondents, which represents 11%, said it's true. So let's hear more from the presentation and learn about it. Dr. Simwenda.
Okay, thank you so much, Dr. Singini. Okay. So again, based on evidence and data, people living with HIV still remain at substantially higher risk of active TB disease, even if they're on ART and are clinically stable, and even if the CD4 count is above 700. Isoniazid preventive therapy works synergetically with ART, meaning that, of course, we need to utilize both IPT and also ART to lower the risk of active TB disease. Multiple studies have demonstrated that IPT reduces TB incidence among people living with HIV and is actually cost effective. So we move on to objective 2. Objective 2, we are going to describe the TPT Sage initiative in Zambia. Very interesting. I hope we are going to all follow up and get excited about this as we go back to our facilities to continue implementing TPT. So I'll hand you back over to Dr. Simwenda.
Thank you very much. So the third poll question reads, indicate whether the following statement is true or false. So I encourage everyone to participate. There's no negative marking. So just click on your preferred answer and we'll be able to inform you of the responses. So the aim of the TPT surge is to achieve 90% initiation and 90% completion of TPT among eligible people living with HIV, both new to care and already on ART at selected sites in the given period. It's a bit wordy, I'll repeat it.
It is.
The aim of the TPT surge is to achieve 90% initiation and 90% completion of TPT among eligible people living with HIV, both new to care and already on ART at selected sites in a given period. So allow me to just launch that poll question. So we have, we'll just give it maybe 30 seconds or so for people to respond. Okay. I have a feeling people from Lewanika General are not responding. I cannot see the numbers increasing. Okay. Kabwe Central, I can see the participants are not getting closer to the device to vote. Please, we value your responses. Thank you so much. All right, so I will end the poll and display the results and see how the voting pattern has been. So the majority of the participants thought the statement was true at 90%, and the remainder, which is 10% of the respondents, thought it was false. Dr. Simwenda, please enlighten us on this.
Okay, so I mean, this can be even a good guess because we're always talking about 90, 90, 90, yes. 90 and things like that. So really the aim of the TB surge in Zambia is to achieve 90% of initiation and 90%, and if possible and above, of completion of TPT among eligible people living with HIV, both clients that are new to care and those that are already on ART. Initially, it was at selected sites in a given period, but we would like to encourage that the completion rate, including the initiation rate, is actually above at 90% or above. Some background there, in 2018, the TPT coverage among people living with HIV new to care was only at 25%, with much lower uptake among children living with HIV at 8%, and at 3% for those ones that were already in care. This was data from 2018. At this time, there were thoughts already that were going around, and then we needed to really do something because this data is quite not good, not even quite not good, was not good at that time. And then with the increasing coverage among people living with HIV, the risk of progression to active TB and decrease in transmission, thereby reducing the TB morbidity and mortality, is required among this population. So with this in mind, a lot of things happened, and we can see that there was a launch of the TPT guidelines there, which I think we have mostly in probably soft copy, but there were a lot also printed out and distributed to our facilities as well. So again, in 2019, looking at the progress that Kenya was making, a team from Zambia joined some counterparts from Uganda and Zimbabwe to learn and the lessons from Kenya's experience, and also come and replicate those lessons learned. So based on the lessons learned, the initiative was actually started and was proposed to aim at drastically scaling up initiation and completion of TPT among eligible people living with HIV, that is both the new to care and already on ART, including the children. So the Zambia RRI was given with the name TPT SAGE. So what has been happening? We can see that there has been a lot. There's policy and planning with a lot of collaborative meetings, partner and stakeholder engagement, finalizing of guidelines with budgeting and planning, and also making plans on how the SAGE was going to be rolled out, including making an M&E plan. Then there's the pre-scale-up stage where there was dedicated personnel that was looked at for the rollout, the development of job aids, the printing of guidelines and tools, the launch of and distribution of these guidelines, including commodity management and health facility readiness checkup, and also training of trainers in preparation for the actual implementation. Then at implementation level and scale-up level, there were on-site training and mentorship, ongoing collaborative meetings that have been happening and are still happening, the data quality assessment and improvement, ongoing commodity management, which is very key in the TPT SAGE, and ongoing training, supervision, and mentorship, as well as monitoring and evaluation. The program is planned to be evaluated at after a 3-year period, which will be very important. Okay, so some data again there. This is PEPFAR data from FY20, which was starting from October 2019 to September 2020, and this is from PEPFAR. We can see there that Zambia has some of the best, if not the best, results on TPT implementation currently. We are very good as Zambians. We learn something and then we come and polish it up and run with it. I can say that South Africa there was the highest. We initiated and had 216,000 clients completing TPT versus South Africa, which is there on top at 287,000. But when you compare the current on treatment for South Africa and Zambia, you can equally say that we did our best, but we can also say that we actually had the best completion rates on TPT. This is very encouraging, I guess, to everyone here. And when you get such results, very good performance, you still want to perform even better. And that's one of the reasons why we are having this discussion today. So again, some data there to really encourage us is on the effect of TPT on TB HIV infections on the period 2017 to 2020. So some of the things that we'd like to look at is where we were in 2017 and where we are now in 2020. We can see that in 2017, out of a total number of 37,203 TB notifications, over 25,000 were actually notifications of those clients that were co-infected with TB and HIV, coming down to 2020, you can see this number drastically reducing from 25,000 to 14,000 out of a total number of 40,756 notifications. So meaning that we have less and less people. Actually, this is about 38% of people living with HIV that were infected that actually had TB, which is a very good improvement as compared to the actual TB notifications. One other thing that is notable here is the completed on TB and on TPT, sorry. So you can see where we're coming from in 2017, going up to 270,000 in 2020. So there's this exponential increase in the access of TPT that is really corresponding in the fall of the rates of TB, HIV co-infection. And also we can see that the rate of TB co-infection has dropped from 60% to 39% between 2015 and 2020. Of course, we note the significant contribution to these good results by increased access to ART and high rates of viral load suppression. So on TPT coverage again, just to encourage us again, so that we can look at the data where we're coming from in 2017, and this is in people living with HIV. So where we're coming from in 2017, we had about 42,000 clients that were initiated on TPT. We increased to 76,000 in 2018, to 189,000 in 2019. And there we were in 2020, almost doubling to 300,000. This is very good. But if we look at the total number of clients estimated to be living with HIV, about 1.2 million, we still have an estimated gap of 500,000. And those ones that really need, for us to reach saturation, we need about 431,000 to be initiated on TPT. So there's still a gap, despite moving from this in 2017 to almost, how many times? 6 times or more in 2018. We still have this gap here to cover, even a larger one, if at all we estimate the clients that are living with HIV. So there's still a lot of work. We've done very well, but there's still a lot of work that needs to be done. And hence the reason why we are here discussing about TPT implementation and TPT SAGE. So in 2021, in the first quarter, we initiated 83,000 clients. So if we look at this number, by the time we are completing 2021 in December, we only have initiated about 300,000, meaning that there'll still be a gap. And if you look at these clients that were initiated in 2021 and completed, in 2017, and completed TPT, it means that we have this cohort and this cohort that are now becoming eligible. So the work is still actually there. So what do we do to continue preparing our sites to continue with our TPT implementation? So I'll hand you over to Dr. Singini for this question.
Thank you very much, Dr. Simwenda. And before I just launch the poll, allow me to just recognize the presence of the other 2 experts on the call. We have, I've noticed Dr. Muyoyeta has joined, and also Dr. Peter Chungulo has joined. So when we get through to the discussions, then we invite for questions and comments, as well as we'll also invite the subject matter experts to give us their expert opinions based on the questions that will arise. So Just also as a quick reminder, I see there's someone with a device, Technopover 3. Please rename your device so that when we call upon you to ask your question, we do not call you by the name of your phone or laptop. Thank you so much. So quickly running into the poll, which is the last poll for the day. It says, true or false? Only the following factors will contribute towards improving TPT uptake. True or false? Only the following factors will improve, or only the following factors will contribute towards improving TPT uptake, which is sensitizing the health workers, the healthcare workers, conduct trainings and orientations, ensure stock availability. Remember the golden rules of multiple choice questions? When you say only, never, hardly, only the following factors will contribute towards improving TPT uptake. Sensitize the healthcare worker, conduct trainings and orientation, ensure stock availability. So out of 295 connections, just a whisker above 50% have voted. So allow me to just give 10 seconds for the others to put in their responses, and then I'll hand over to Dr. Simwenda for this the last two parts of the presentations. So 5 seconds more. Dr. Simwenda, I'm sure you can see the interesting pattern of votes that's happening. So I will end the poll and share the results to allow Dr. Simwenda to give us a comment on and also to give us information surrounding this question. So we can see that about 59% thought the answer was false, and 41% thought it was true. Dr. Simwenda.
Okay. Thank you very much, Dr. Singini. Very interesting responses there. We'll definitely go and look at what factors contribute towards improving TPT implementation as we describe how to conduct site preparation for TPT implementation as our third objective. Very interesting. Again, please pay attention. This is very important because all these factors that we're going to mention are very key in improving our TPT implementation. So very important is the high political commitment, the willingness of the high-level officers in supporting TPT implementation. So these are the policy makers. Okay, so this is very important because TB is not only a local burden, but it's also an international burden as well at global level. So these here sit in high-level meetings where TPT implementation, prevention of TB is actually advocated for. So these are very key as well. Partner support in terms of various resources that are required for TPT implementation is very important. We do not forget community where these clients are coming from. So community engagement is very key, as well as commodity security. Management of the commodity security is equally key to improving TPT uptake. So, like I mentioned, the stakeholder engagement, which actually we have done or has been done as we march towards accelerating the UN HLM targets. So these are the United Nations high-level meeting, targets that was actually held to advocate for improvement of TPT at a higher level. So the stakeholder engagement here, there's commodity management, which is key, and then the launch and implementation of actual TPT. So definitely this started in 2020 and it was planned for 2020 and it took off. We are still surging and we will not stop until that gap is covered. But remember, even when the gap is covered, there are still clients that are going to continuously be eligible for TPT. At facility level, and that's where most of our questions actually came from. Okay, in addition, of course, we need to sensitize the healthcare workers, very key people as well. We conduct the trainings and orientations, including the mentorship as well. Ensure stock availability at facility level, which is also key. So I think you can see where we are standing with the poll that was put up. Okay, so we move on to the last objective, which is discussing the next steps to effectively roll out TPT in Zambia. This slide has come again. I think we know what this slide stands for, is actually telling us. We know that we still have this gap here and the one in green to reach saturation. But we also know that we have these clients here. We're now in 2021, isn't it?
Yes.
So if we go back to 3 years, we could go 3 years backward, it will be 2018, but we still have these. Okay, and these, and very soon these, that will become eligible again. And yet we have not yet saturated when we look at this part of this chart. Okay, so just a reminder again that we still have a lot of work. We still have a gap there to cover. Okay, so the estimation of coverage by the end of 2021 is at 332,000. Again, it means that we will not reach saturation at the rate that we are going, that is at 83,000 per quarter. So we need to search, we need to continue initiating those eligible clients. So what are the proposed next steps? Target setting is very key. Target setting can be done at a higher level, maybe at national level, but very key to reaching the target is looking at facility level targets. So the target setting 2, facility level target setting 2 will be rolled out. So this is where facilities will be able to utilize this tool in order to set targets and to ensure that they reach the target, especially looking at those clients that are eligible for TPT. Reviewing of the facility targets after the targets are set, definitely it's very important to review the facility targets. We need to aim very high, definitely, but we also need to look at what is prevailing on the ground. But in mind is that we have all this support that has come in as we looked at national level, at a higher level, there is political and also there is a policy that is driving this program as well. Supply the facility with the adequate stocks of commodities. This is key. We cannot implement a program without the commodities. So this is going to be looked at as well. Very much to be reviewed frequently so that we ensure that the adequate stocks are always available at facility level. COVID-19 has hit us very hard in all aspects of our health services, including TPT implementation. So we would like us to draw up a plan for TPT implementation amidst COVID-19. Let us sit down and draw up plans as our next steps. Roll out TPT surge towards saturation. Remember the numbers that were presented. We haven't yet saturated, even though we have noted and really appreciated our work. We haven't yet reached saturation. There's still a lot of work to be done. So we still need to roll out. We still need to scale up. 3HP rollout to be scaled up in the district where the initial rollout had started, and even to scale up to other and roll out to other districts. So we're very excited. 3HP has come in. It's already being implemented, and clients are already being initiated on 3HP. Another key component of our next steps. So we have this presentation quite all right. We have really looked at it starting with the evidence to convince us to increase our confidence, and then looking at why the TPT SAGE, looking at site preparations and the next steps. The onus is on us to really discuss here, go back to facility level and think through what we have really discussed. Of course, acknowledging that we have really worked hard, but there is still a gap. So thank you so much for listening to the presentation. We'll definitely discuss more. So I'll hand over back to Dr. Singini. Thank you.
Thank you very much, Dr. Simwenda. That was a very concise presentation, and it has really brought to light what we have done, what we are currently doing, and what we need to do for us to reach saturation for the TPT coverage in Zambia. So at this point, we are going to get into the next part of our session, which is the discussion. At this juncture, then, I will invite participants that have questions and comments to signal to me by raising your hands. While you are at it, allow me to look through the chats and just bring to light some of the comments and questions that have been submitted. So we have one from Dr. Charles Lushinga from Western Province. He says, total TB notifications have remained static with a slight increase, but notifications among people living with HIV who are receiving TPT have actually dropped. This is evidence that expansion of eligibility criteria for TPT would be a good idea. Thank you, Dr. Lushinga, for your comment. And then there's also a comment from Conrad Msonda from Kabwe, who says, with the increase on TPT, I noticed the number of TB notifications decreasing, but a significant increase in HIV negative people. Does it mean you may consider TPT in HIV negative people, or what extra measures are being implemented? That is a very good question, Conrad. If you may, please just unmute yourself and just add more flesh to your comment, and then we'll have Dr. Simwenda and the subject matter experts that are on the call to respond to you. Conrad?
Hello, good afternoon.
Good afternoon.
Hello, can you hear me?
Yes, we can hear you loud and clear. Please go ahead.
Yes, from the data that was presented, I noticed the number of TB notifications among HIV positive people has decreased significantly, but for the negative ones, the numbers have been increasing. So my question is it possible to expand TPT eligibility to HIV negative people so that we reduce the overall incidence of TB in the population? Thank you.
Thank you very much, Conrad. Dr. Simwenda, would you like to speak to that?
Yes, I can speak to that, and I guess he's referring to this slide. Is it Conrad?
Yes,
Is
Conrad.
this a slide that you're referring to? So, which is actually true.
Yes.
Yes, and I would like the other panelists to actually come in. So, of course, TPT implementation with a focus to the HIV positive people living with HIV has really helped a lot, especially on the TB notifications. And we can see this reduction, and yet in the HIV negative, the difference between these is actually what it is. So we're not saying that the non-HIV people are actually they're not eligible. Including ourselves here, the healthcare workers, we are at risk of TB. We are actually eligible. We have the mine workers there, whether they're HIV positive or not, they are actually eligible as well. The main focus, if at all we looked at the data, we go back and looked at the data, was on the HIV positive, because at that time, there were a lot of new infections in people living with HIV as compared to the HIV negative. So that was the thought process from that time. But the data has changed. The landscape has now changed. And it's always good to be informed by data, so that whatever actions we make, any policy decisions that we have to make are based on the data. So this is what the data is showing us. And exactly what you said is what is supposed to be done. We need to also focus on the HIV negative that are also at risk. So I'll ask also the other team members, the panel of experts, if we have Dr. Lungu, if he has joined in now, I would like them to also participate. Dr. Mwinga, Dr. Myoeta, Dr. Chungulo, please, you can come through, as well as Dr. Lungu. Thank you.
Yes, Chair, thanks. This is Dr. Mwinga. I think you've ably addressed the question. If you look at the previous Zambian guidelines, we were still giving to the HIV negatives, but only that we are restricting it to the under 5s. But the current Zambian guidelines actually dictates that for all those close contacts of someone with confirmed TB, they can actually be offered TPT for as long as they qualify. So we've opened it up to even the HIV negatives, so that we reduce the TB in the general population. Thanks.
Thank you, Dr. Mwinga, for that addition. Any other additions, Dr. Myoeta, Dr. Chungulo?
Hi, thanks. So yes, the subject has been ably handled, but I just wanted to add that the thinking, even after the guidelines were revised to expand the inclusion criteria to other high-risk groups, so other HIV negative high-risk groups, I think as a program, we've kind of like continued prioritizing people living with HIV, a lot to do with logistics as well as supply chain. So to ensure that that group of high-risk population reaches saturation. Not to say that the other high-risk groups are not important, but we also know that this high-risk group, people living with HIV, are also at very high risk of poor outcomes when they get tuberculosis. Thank you, over.
Thank you, Dr. Myoeta, for that addition. At this point, network, allow me to invite questions from the participants related to the TPT surge and what has been covered in the didactic presentation. If you have a question, please signal to me by raising your hand, and I will be sure to pick on you. Dr. Chungulo, any additional comment you'd like to add to what Dr. Mwinga, Dr. Simwenda, and Dr. Myoeta have spoken about?
My colleagues have ably answered the question. You know, the issues about the benefits that we are getting. So this is the cost. If you look at people living with HIV, we get more benefits. We are not going to have complicated TB and so on. So you have to look at the supply side also, as Dr. Monde said. Are we going to manage really to put a lot of people who are not living with HIV on TPT? Let's look at our past, at our history. I think the situation is just stabilized now in terms of drugs. We don't know, unless we are very, very assured that we are going to have the drugs throughout. Thank you, Mr. Chair.
Thank you, Dr. Chungulo. I can see there's a hand from Dr. Muviana Mbewe. Please unmute and give us your comment or question.
No, thanks a lot for the presentation. Sorry for the echo. I have two devices. I just wanted clarification on the TB incidence that was reported in the presentation among people living with HIV. Is that for the general HIV population or those on treatment? Or I mean on ART.
Okay. Thank you very much. Dr. Simwenda,
Was that clear?
Speak to that?
Okay, so we're still on the, you're referring to this data, isn't it, on the notifications?
Hello, can you hear me?
Yes, Dr. Muviana, we can hear you. So
sorry, I couldn't hear the
response.
response. Apologies,
Okay.
I didn't hear that you were talking. Yeah, you can.
Okay, all right. So I'm just getting clarification. Is it still on this slide on the effect of TPT on TB HIV? Because there are a number of slides that have TB incidents, particularly this one
Sorry,
is
it's
for
not
the
on
Zambia.
the effect of TPT. It's the general TB incident among people living with HIV.
Okay, I'm trying to look at this slide, but the data that we presented earlier on the incidence was from studies that were done at global level. So we have the Temprano study, the Ethiopia study, and also we have the Vietnam study. We haven't, the only data that we have for our status here in Zambia, and that has been presented, is this one here, this slide.
Sorry, maybe it's not clear. We have 10% incidence.
Hi, Dr. Mangala, let me come in.
First 2 years.
Oh, the
Yes,
initial
thanks.
10%. That is
Yes.
HIV.
Is the population of those on ART or just? Yes, yes, I know it's HIV.
Yes.
Dr.
Yeah, this is the
Mnyoeta,
one. So
Yes, this one. This one here.
Hi. Hi.
Please go ahead, Dr. Mnyoeta.
Hi, I've understood your question. So my response to this is that a lot of this data that we are using, the evidence that came out, I'm not aware of new evidence that has come out measuring the incidence of TB in people living with HIV after the advent of ART. A lot of this data that we study of TB people living with that the incidence of it to be higher in people living with HIV, regardless of them being on ART, higher compared to HIV negative patients, because we know that the immune recovery does not revert back to HIV negative. So 10% from what I recall and what I know is evidence that came out before the widespread use of antiretroviral disease. I hope I answered your question.
yes, you have. Thanks, Dr. Samuel. The reason I'm asking is that my previous knowledge on TB, when I was on TB, I think we learned was that incidence with HIV. HIV was actually 10% per year, whereas for a person without HIV, it would be 10%. So I wonder if this was with ART or not.
Thank you very much for the comments and questions, and also the responses from and Dr. There's an interesting question in the chat from Kings, who's asking, when are we going to see the role of 3HP in the facility. So Kingsley Kachingwe has asked, and I've noticed Dr. Lungu is now on the call. Dr. Lungu, would you like to speak to that?
Thank you, colleagues. Sorry, I've joined the meeting late. I'm happy to take on this question. So I would like to say that we have started the rollout of 3HP. Every province now has 3. I can confirm that Western Province has, Central Province has, Copper Belt also should have already picked up the commodities. The Coast have picked up. So PHP rollout has started. Unfortunately, it's being done in a staggered manner. For every new molecule, I think that's the model of approach. So even with the introduction of 3HP, we should not drop the ball on INH. So for those who are already on INH, we should continue. And only the new in take on 3HP, and all those that did not complete INH are the ones you could give an option of 3HP. So in a nutshell, 3HP is in the country, and colleagues, let's ensure that patients are commenced on 3HP where it's available.
Thank you very much, Dr. Lungu. So, dear network, at this point, I would like to ask anyone with a question to simply unmute yourself or raise a hand to ask about the subject matter today. Yes, please go ahead and mute yourself and give us a question or comment.
Yes, good afternoon.
Good afternoon.
I was looking at the data where we're not doing very well when it comes to TPT initiations in pediatrics. I think the challenge that we have, and of course, when you compare the data, you find out that even those that are on RT, the new clients, mostly most of the numbers, they are low in initiation of TPT. The issue really, when it comes to pediatrics, is the regimen they are on ART. We know that is already there is few burden of taking BD, the treatment. Then you are looking also, you're comparing as well when you look at the suppression rate in pediatrics, also it's another issue that is happening countrywide. Where now we are quite skeptical of, can we initiate TPT on these pediatrics while they are having problems with their viral load? Do you think that probably pure burden there will be an issue again to adherence to treatment to ART? And the same reason can be given to those who are newly initiated on ART. These are the people that have just received the news of being HIV positive. Then they are in the process of accepting even to take this then you introduce again the TPT for 6 months. We also question, also as clinicians, we come to question the adherence, how it will be, the quality you can give them, but how sure are you that the uptake will be good when they go back in the community? So that is the challenge that we're having in initiating those two parameters. That's why you find that we have a lot of challenges and it's contributing to the low number of initiation. Thank you.
Thank you very much for that comment plus question. I think it will be amplified. You really spoke to the TPT coverage in the pediatric population. There's another hand from Maureen Zumara. So let's have you, Maureen.
Thank you, Doctor. Mine is a quick one. I just wanted to find out if it's safe for the new drug, the 3HP. Sorry, I joined in a bit late. Is it safe to be given to pregnant and breastfeeding women?
Thank you so much, Maureen, for that question. I'll ask one of the subject matter experts to attend to that. There's one more question in the chat, which came from Lusaka province, saying contributing on the performance of TPT, sometimes the challenge is stock out of vitamin B6, because like at my facility, we use B6 for both TPT and TP. So I'm appealing to ZAMRA to at least be supplying a lot of B6. So Dr. Lungu, please take note of that comment, and I will ask you to speak to that at after we've tackled the first two questions. So I will ask Dr. Simwenda to speak to the TPT in pediatrics with respect to the pill burden and handling children having high viral load. Dr. Simwenda.
Okay, thank you so much, and thank you for the challenge that we are having on the PIDs. And I think we all know as clinicians, we all know as healthcare providers that the pill burden is actually more in the pediatric clients than in the adult clients. Having said that, yes, again, the viral load suppression rates are lower in the pediatrics as compared to the adult clients as well. But what we need first to understand really as benefits in the pediatric population as well. We need to be convinced that this is actually required. This is actually, they actually need it as well. And so with that conviction, we can be able to put in measures in place to ensure that for those pediatric clients, and by the way, it's not all of them that have challenges with adherence, for those ones that we have noted to have challenges with adherence, we bring them closer to us. If it's making sure that we have a CBV or someone following them up, we do that. But on the other hand, such implementation as TPT is not just a single-handed implementation. There are a lot of things that are happening even on the HIV program, especially looking at reduction in the pill burden of clients, children living with HIV, including the introduction of DTG that will soon be introduced. It will lower the pill burden, including the introduction of the granules as well, which are proving to be helpful in the younger children. So we need to put in a lot of things together. We need us as clinicians to help those children identify to have challenges with adherence. Let's not deny them on the basis of their low viral load. Let's work out on their adherence issues. Let's engage their caregivers, let's engage their parents, and we also have talked about community engagement, really looking at what are these factors around their environment, including their household, that are making them not to be adherent to the ART, that will probably make them not adherent to the TPT. So let's approach such matters in a holistic manner. And let us be convinced first. If at all we're not convinced as healthcare workers, we will not manage this, because this is a huge challenge. So specifically, I've forgotten the name. The way you're coming out, please let us, we take it as our responsibility to take note of those clients that are having challenges, the PIDS clients that are having challenges with ART, and support them in a holistic approach.
Thank you so much, Dr. Simwenda. There are two other questions that are pending. One is on the safety of 3HP in pregnancy. I'll throw that to Dr. Mwinga, then we'll have Dr. Lungu comment on the logistics on availability of vitamin B6. But before we get to Dr. Mwinga and Dr. Lungu, allow me just to invite a comment from the clinicians in the field about how easy it has been to convince caregivers to give TPT to children. So like was mentioned, we are less than 13% TPT coverage in Zambia. So I'd like to learn and probably also learn the network to learn what we are experiencing in terms of convincing caregivers, mothers to children. I'll just call upon Dr. Imamba from Lewanika General. I know I've put you on the spot, but what's been your experience with TPT children, and how's the acceptability in your area?
Yeah, thank you very much for that question. In my practice area in this in the Eastern Province, mainly what we see is I think the main problem is not about being greedy, but the bigger problem is patients being able to confidently say this child doesn't have TB and requires prophylaxis treatment or requires TPT for prevention of TB. So I think that is the main gap, not the acceptability. In my practice, I think that isn't a problem. Thank you.
Thank you very much, Dr. Imamba, for speaking to that. So, Dr. Mwinga, please go ahead and help us answer about the safety in pregnancy.
Thank you very much. And with your indulgence on what Imamba mentioned, answer that question. I think that Dr. Imamba is a critical issue. The biggest problem we had with TPT initiation in PIDS was ruling diagnostics for us to test for TB in the PIDS. But now we have urine lamb and we have stool that is being used as a sample for expert. So with of these added investigations, we can actually confidently rule out TB in pediatrics and have them put on TPT if they are negative. Then coming to the question on the safety of 3HP in pregnancy, I think Dr. Lungu did highlight that the 3HP has been sent to the provinces, but for Lusaka and Copperbelt and Central provinces where we did do some training, for the other provinces we'll actually do a training that I mean, we'll have to do a training before you start using the 3HP. And in that training, the AEs and the pre-qualification for who should be put on a 3HP will come, will be addressed. But the question in a nutshell, 3HP has not yet been validated for use in pregnancy, those breastfeeding women. So for those ones, we may actually have them still use INH. Over and thanks.
Thank you, Dr. Mwinga, for that timely response. And I can see Dr. Kozia Ziambo is actually agreeing to your statements and actually confirming that your response was very timely. So I'll move on to Dr. Lungu related to the logistics, particularly B6. Dr. Lungu.
Yeah, thank you very much for that question on the B6 logistics. But before I tackle that aspect, let me just commend Dr. Mwinga as well as Dr. Simwenda for taking up those critical questions. But I beg the indulgence of the two if I could just supplement their responses. For me, I think I found that the questions were adequately responded to, but I would like just to supplement the question on the challenges of TPT in children, especially those who have not virally suppressed, that a family approach will be quite critical for us to implement TPT amidst such challenges in those patients. And the family approach is where you bring in, if there's an existing, if both parents are existing, you bring them as critical entities or stakeholders in the care of that patient. So the father is often left out, and that's where most of the things break down. You may convince the mother, but you go home, they go home, they meet the father, and the father just says no to certain aspects because of his misunderstanding and the like. So bringing him into the care of the patient, especially the children, will be a major breakthrough to some of the challenges that we have children. So I just to supplement that a family approach will be quite critical, and also a very good counseling. And also just to amplify what Dr. Simwenda said, that to begin with, ourselves as healthcare workers, we have to be convinced. And colleagues, data is showing us from the national level that we are having, with increased surveillance, that we are seeing a lot more children contracting TB. And they severe forms. Just to share with you that when a child has TB, they are likely to suffer TB meningitis, and the likelihood of it affecting their intellectual ability is very, very high, besides it causing mortality. So we should actually be very interested and also be deliberate on TPT in children. With regard to breastfeeding women and pregnancy, Dr. Mwenga, I beg your indulgence just to supplement this. There's been a lot of reluctance to give TPT in pregnant women, and for the reason being that is and the like. Of course, there are a number of studies that have shown some adverse effects and the like. But WHO, with their vast data that they have reviewed, actually there's no enough evidence to say to the contrary. Essentially, there isn't enough evidence to challenge that TPT is not needed in pregnancy. Just to share with you, even in our setting, that TB is one of the leading causes of mortality from non-obstetric causes. So among non-obstetric causes, TB is leading in terms of causing mortality. And also not only in those who are expectant, but also in the puerperium period. I will share with you that from the program end, we are having challenges with a lot of MDR cases in the less than 1 year old children. I'll tell you that it's difficult to treat a DRTB who's less than 1 year old because you have to crush all the tablets. And there hasn't been very good drugs for this population. Essentially, we're using adult drugs to treat children. So, and then this in itself shows us that we missed an opportunity to have prevented TB in the under 5 by treating the mother or by giving TB preventive to the mother when she was pregnant. Just locally here last week, we were looking at data coming from Chilenge. I'll share with you that Chilenge is one site that has implemented TPT in pregnancy. Last year alone, they had put over 180 patients on TB preventive therapy. And among those, 150 completed TB preventive therapy. That completed, none had effects. Of course, we are still looking at the data in terms of other outcomes, but essentially it's proving to be very safe in pregnancy. So we should not fear to prescribe TPT in pregnancy, having ruled out TB. Of course, the safety measures to be adhered to by checking if there is any hepatic injury due to the drug. So essentially monitoring just has to be heightened in that population. So I thought Dr. Mwenga and Dr. Simwenda should supplement your ably responded to questions. Then coming to my question, colleagues, one of the things that the challenge we are having with B6, I would call it an artificial shortage. Artificial shortage in the sense that we've quantified for every tablet of INH, we've quantified an equal amount of B6 required at national level. The pressure on B6 comes due to multiple uses. You find individuals with painful eggs are being prescribed B6, so, and other uses as well. So that creates some artificial shortage. So the other thing is, whenever we receive, I think we'll be a bit more deliberate on addressing this issue. Once we do consult with clinical care, then we'll issue a very comprehensive guide. And large, as facilities, pay attention to your B6 quantities and order your B6 in large amounts, sufficient for the number you're targeting. I don't know if this was covered. The president encouraging you is to develop, you need to develop your facility level targets. And to that effect, we have developed a tool that is going to enable you to develop facility targets based on your data, your past report put and indicate to the number that you are remaining to cover. So please look out that tweet has been circulated, and at a facility district level, determine your targets. This in itself will also give you the quantities of iron that required to treat patients. So in a nutshell, those are the comprehensive approaches for us to mitigate these recurrent shortfalls that we're experiencing. So a more comprehensive approach would, but in the meantime, colleagues, let's just ensure that we utilize that tool that has been circulated, we determine our need, and secondly, we order adequate. Whenever you are about to run short, quickly, we should be able to help in responding to some of the shortfalls in B6. At no time should we prescribe INH without B6 because it's got serious implications on an individual. So it's a very important commodity ought to secure. Chair, I submit, and pardon me for that length.
Thank you, Dr. We appreciate the questions that have been just indulged the expertise of the subject matter experts on the call to answer a few questions that are in the chat box. So I'll start with Dr. Chungulo. I'll give you two. The first one is, what is the guidance on initiating plans on TPT who are finishing or finished ATT? Because they say initiation should be done immediately, while others say it should be done after 3 years. So that's question one. The second question for you, Dr. Chungulo, is how many months are to be dispensed at initiation? So maybe you can speak to those ones. Please prepare to respond to what is the approach to people living with exposed to DRT. So similar to that, the last part. So Chungulo.
Oh yes. Definitely talking about the guide initiating class for people who are finishing or finished, because others say immediately while others say after 3 years. Yeah, I think this is quite a team. I think what is very, very important is that you have to give a bit of time. Of course, it's after 3 years, but you have to give a bit of time before you can initiate them. What I would say is that you have to make sure that you actually have ruled out TB completely. I think that's the answer I have, unless my other colleagues have other answers. Then how many months are to be dispensed at initiation? Again, just talking about the stability of the clients. If you feel that the clients might not have any side effects stable enough, you can still give it depending on the type of TT that you are giving. So if it's INH, you have to give months or can you give for 3 months? If it's PHP, I can use the unless there are other answers. Thank you, Mr. Chair.
Thank you, Dr. Chungolo, for the two questions I asked before we get to the DRI posed.
I think he has answered. So if someone of ATT, that is TB treatment, and TB treatment has got INH in it. So you could actually wait for 3 years before you could give TPT, unless there is a clear documented case, domestic or indeed very close TB exposure. That's when you might actually decide to give the INH before that period has elapsed. Then with regards to the frequency of how you administer the TPT, I think now we are moving towards integration of TB and HIV dispensations. So you look at this is on 6 mmD for AR. Indeed, you might go that route, so that will minimize on the number of reviews that he or she has to facility. But of course, with clothering, using community to that treatment. So we want to dispense TPT with the ART dispensation model. We try to follow that DSD model so that we make it easy for the client measures. Over and thanks.
Thank you very much, Dr. Mwinga. Quickly, just a quick feedback on the question about what's the approach to people living with HIV or children exposed to drug-resistant TB. Dr. Myoyeta? Okay, seem not to be seeing Dr. Myoyeta.
Hi, I'm here.
Okay.
Yeah, so the guidance that's currently provided, I hope you can hear me, individuals who are exposed to, so for contacts of DRTB patients, there are several. So first of all, there has to be very clear or very careful consideration. The drug that's recommended is levofloxacin, but however, that is only given if the patient that the client has been in contact with, their drug susceptibility testing profile shows that they are not resistant. To take a step back. So let me just take a step back and say this properly so that people can follow. So it needs clear first of the intensity of exposure, then has to be certainty of the source, and then you need to know the drug resistance pattern of the source case, because there's no point in giving, for example, INH if the point source was INH resistant, or levofloxacin if the patient was resistant to fluoroquinolones, as an example. Okay, so in short, the drugs should be selected to drug susceptible of the source case. Where possible, it's also encouraged that we actually confirm the latent TB being a TST or IGRA test. So I think in short, we are saying is that it's not very straightforward to give prophylaxis for drug-resistant TB contacts. And one of the recommendations as well is that preferably this should be done as well as the expert committee for the province. Thank you, and all that. And this is because of why it's not so straightforward. The evidence very clear, and then we know that a lot of our patients will also be resistant to INH, and rifampicin, which as the two of the drugs that we use commonly as well in preventive therapy. Over. Thank you.
Thank you so much, Dr. Myoyeta. We have under 5 minutes before the hour mark, and I can see there's quite a lot of questions that have been asked in the chat box. And I must be quick to apologize to the network that we might not be able to respond to all those questions that are in the chat box. However, for those whose questions have not been responded to, please take note of them and forward them to us through your mentors in the sub-districts or the districts, and we should be able to provide feedback to subject matter experts. So of note among the questions that is in the chat is, what is the approach to a client who stopped, a client who has stopped TPT for the last 3 months and they only took 4 months. In other words, they didn't complete the 6 months course. A quick response, Dr. Mwinga, before I ask for the summary. A client that started TPT, took for 4 months, dropped off, and they defaulted for 3 months, and then it comes to light. What is the next step? Do you continue for another 2 months or you restart at 0? Dr. Mwinga? Okay, we may have Dr. Mwinga. Dr. Simwenda?
Yes, so on restarting TPT, the guidelines are clear. If someone has been on TPT and they have stopped or defaulted for a period of 4 weeks, we actually have to restart the so in this is a long time. The client had taken TPT for 4 months. So we really need to ensure that clients understand the importance of completion, so that we also don't waste the commodity as well. So any client that has defaulted or stopped for a period of more than 4 weeks has to be restarted on a TPT. Thank you.
Thank you, Dr. Simwenda. And also thank you for taking us through the didactic presentation. I'd also like to thank the subject matter experts that we've had on the call, Dr. Mwinga, Dr. Myoyeta, Dr. Chungulo. We really value your support. At this juncture, we invite the NTP chairperson to give us concluding remarks, and we'll sum up our session for today. This has been Dr. Singini from SIDA's TB department as your facilitator. Dr. Lungu.
Thank you. I would like just to begin by thanking you for the active participation, and also just to sum it up by saying that TB preventive therapy is not only a preventive measure for TB, but a life-saving measure. Therefore, we need to implement TPT to scale. We need to work collaboratively as one so that we achieve full saturation. Already from the data that we have from both HIV and TB program is that TPT is safe, and also that TPT is effective in preventing TB. And we are relying upon you, colleagues who are at the grassroots, to implement these life-saving interventions. Wherever you have challenges, I think reach out to both the TB and HIV program, and we will be responsive to the things that are emerging. Let's not keep the problems and challenges with ourselves, within the province, within the facilities. Let's consult one another, engage on this subject matter of TBT so that we can resolve and save the patients very well. With that, let me just thank Dr. Simwenda for taking up the mantle of presenting on this very important subject matter, and also other discussants, Dr. Linus Mwenga, Dr. Mueta. If I've left out anyone among the key discussants, Dr. Chongolo, on me. And also just to thank the facilitators, yourself, the chair, and Wedi for facilitating this very important intervention. If there are any questions, we remain ready to respond to them, colleagues from the national level, both from TB and HIV program. With that, I thank you and wish you a very fruitful week. Bye-bye.
Bye.
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 Au revoir.
Bye-bye.
Bye.
Bye.
See you next week, Monday.
Let me just close the app.
Hey, people.
Nice one.
Hello. Good afternoon, mommy.
Well done, Dogini. Well done,
Any
Maureen.
problems?
Mr. Wade, well done for organizing.
Tomorrow.
I know you are the little.
What's the date tomorrow?
So grateful for the team, out there. Well, I think, a great team. I was sweating early in the morning.
Yeah, I know, but you did so well. You did so well. And that's what ECHO is about. You get some minute cancellations. But that's why we have teams. As you can see, the TB team was able to organize themselves. Dr. Sinjini, at short notice, was able to step in. So well done to you for bringing everything together.
Thank you so much.
Great
I'm
presentation.
very grateful to the team.
Very important topic.
Yeah, and Wedi.
Yes, please.
Dr. Singini is at your disposal when you need help.
Thank you so much. I think, is an added resource.
Dr. Simwenda, thank you very much.
Oh, sure.
Stepped in on time.
Yeah, I can afford a smile.
Dr. Sinjini, you said we are from the TB department outsiders. Forgive my background.
Yes, so.
Dr. Samba, I'll call you.
It has okay. Congratulations are in order. So and perfect for this. Wedi?
Yes, please.
You have someone to double. He's very well trained and can help with everything. So you are a very lucky man, Wedi.
Sure.
All right, bye everyone.
Well, thank you and bye-bye. Thank you so much, Dr. Simwenda and everyone. Thank you. Bye.